Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome back today with Chuck Dowell and myself, but we're discussing non-orthopedic causes of pain that present in orthopedic clinics. What about pelvis and hip pain? And that, to me, was a little bit of a question. What kinds of things could cause that? And the first things that come to mind would be GYN cases. Females with pelvic inflammatory disease, PID, UTIs. What do you think about that, Chuck? What kinds of things come to mind if you think about the pelvis and hip pain area?
Yeah, I agree with what you said completely. If somebody comes in and it's a female with kind of more vague complaints, and again, I don't think their clinical symptoms and radiographic symptoms and our findings are matching. I'll often think GYN. I've had some polycystic diseases and or cystic diseases that have potentially caused one-sided kind of vague anterior lateral hip pain. Sometimes UTIs can kind of cause similar symptoms as we discussed before for the low back pain. And so I agree with you completely. I think most of the time in my experience, if I explain to a patient, your symptoms do not seem musculoskeletal in nature, this is the reasoning why they're not, I don't think they're musculoskeletal. This is my concerns. And this is why I think we potentially have to go to the emergency room for imaging. 100% of the time, the patients are always understanding of that if you explain the reasoning why and your thought process behind it. I think the patients that are not understanding is if they come in complaining of it and you just say you have to go to the ER to get an evaluation, and they don't know why they're necessarily going to the ER. So with the PE discussion, I've caught a couple of those in the clinic, and sometimes I'll have them walk around the clinic with the pulse socks on to see if there's any VQ mismatch that potentially makes me more concerned for like a PE type symptoms, especially during those COVID days, as you said, and that hypercoagulable state with the COVID days. Or if they have any underlying, they just had a surgery and now they're complaining of some shortness of breath or difficulty breathing or labored breathing. I think the big thing there is just explain to the patient your thought process, and they're always understanding.
Yeah, I think if you tell them, look, I know what I am seeing and what I have in front of me, I can kind of figure some things out, but some things I can't. And you have symptoms of something that could be really bad that could kill you. And I think that you need to go to the ED to make sure that you don't have that. That's usually reason enough to get them over there. Another thing that I was thinking about, what about inguinal hernias? People get those, and you will have different kinds of presentations with that, and it's not always an obvious thing. You can't always examine that. I've checked for hernias on physical exams, sports physicals, and things, and it's not always obvious. And if I didn't say that, the general surgeons that I've worked with in the past would probably shoot me. But yeah, I think hernias are another thing that you need to think about.
Or even sports hernias. Sports hernias is a big topic in the sports community. You'll have a adolescent athlete come in complaining of similar vague hip pain. And if you check for a hernia, they may not have necessarily those herniatic symptoms or bulging with Valsalva maneuvers, but they could still have this kind of weakness in the abdominal wall that we consider the sports hernia. So as you said, always keeping your mind open to think outside the box on some of these more vague symptoms that aren't clinically matching, I think is important, and trying to know an appropriate differential of not just musculoskeletal complaints, but also other medical complaints that could be causing the symptoms.
All right, great answer. So we've kind of worked our way through most of the musculoskeletal system here, with the exception of extremities. What do you think about extremities? And granted, this is probably somewhat biased toward the lower extremities, but I had a few things that came up. And the things that really stand out would be vascular or neurogenic claudication. And that was my second golf story from this weekend. A buddy of mine is having this diffuse pain, and he's had knee arthritis for a while, but he can't really, he says this is different. It's just something. And so when you have that, you need to think about, well, diabetic peripheral neuropathy, vascular claudication, somebody that has peripheral vascular disease. All of those things are things that can cause pain. DVTs can certainly cause pain and swelling. And by the way, my experience with DVTs is not the classic book. Sometimes they come in and it's just a swollen extremity, it's tender, or sometimes you can feel a palpable cord, whatever. A lot of times it's not so cut and dry. and you kind of have to get that Doppler ultrasound to be safe. And I think those are the big things that I could think of. What do you think, Chuck? What about extremity pain that's not really an orthopedic condition?
Yeah, I agree with you. I think, obviously DVT is probably one of the bigger complaints. I agree. I tell patients that all the time. I stop predicting the possible results of the ultrasound because I've seen DVTs in all different forms and fashions. I've seen a young 25-year-old gentleman with no risk factors coming in complaining of vague popliteal pain. And I sent him for an ultrasound. I was positive for a DVT, and he ended up having to be on, anticoagulants for 6 months. And then I've seen the palpable cord. I've seen patients that I could swear would be a DVT and would come back negative. And interesting, just anecdotally in my practice, I have a foot and ankle doctor that probably is more prone to send patients for ultrasounds. And I think consistently picks up more ultrasound positive DVTs than anybody else in the practice. And I don't know if that's because he's sending more patients for the ultrasounds and we're just getting more of these possible SVTs that have turned to DVTs, or small DVTs that, we don't really recognize. And typically the patients become asymptomatic before we even evaluate them. And so he'll often put patients on to aspirin with ankle fractures or lower extremity injuries that he's keeping non-weight bearing because of this higher propensity for him to get these positive ultrasounds. I also think swelling's a big complaint. I don't know if you get that in your area, but I get a lot of patients come in just complaining of lower extremity swelling. No fall, no trauma, no injury, just noticed increased swelling diffusely throughout my lower extremity. And then you have to put your medicine brain on, as you said, and think, hey, is there a reason for this? Is there a lymphatic concern? Is there a vascular concern? Is there, a cardiac concern, a pulmonary concern? Why are they having the swelling? Is it dependent edema? Is it, what's the word, pitting edema that could be causing it? And, what potentially, is there an underlying musculoskeletal disorder that's causing it? And lastly, as you mentioned, neuropathy is a big one. I have a lot of patients with diabetic neuropathy, and they come in with vague lower extremity complaints. And I think you have to understand, in those patients, their ability to sense pain is significantly less. And a lot of the times, if we miss something in those patients, it can go on to have fairly disastrous outcomes, especially wounds or fractures or small soft tissue injuries that can then progress because of their inability to modulate their pain as a receptor for them to know how bad things are getting. So I think it's really important to keep all of those things into consideration.
Yeah, absolutely. It's not uncommon that you're going to see some of that. And the peripheral edema, yes, seen it hundreds, thousands of times, and it's maybe orthopedic related, but a lot of times it's not. It's vascular, CHF, all of those things can cause edema. So keep in mind what we're trying to do is just remind you to put on your thinking cap sometimes and don't get tunnel vision. It's not always exactly what you think. It could be something, or it could be a comorbidities. It could be different problems that are causing this complaint. So just think and just remember that there's not always just one answer for every problem. Listeners, please follow up next week. Hope you can join us at one of our upcoming CME meetings. We have our Ortho in the West annual conference, March 28th through March 30th. Look on paos.org for details.